Hi, everyone. My name is Nina Resetkova, and you're joining us for the webinar this evening. We're just letting folks join on. So we have a lot of people joining in today. So I'm just going to give everybody a couple of minutes before we jump into the session. Just so you all know, I am going to do a little bit of an intro for the first maybe like 15 or 20 minutes just to jumpstart the session. And then if you have questions as we go, feel free to post those and we'll be able to get through, I think, a lot of questions as well. So the intro session is just to give a little bit of background about LGBTQ plus fertility and donor sperm. And then it'll be kind of a good jumping off point to get us started for the Q&A session. Okay, so 7:01, so we'll give everybody a couple of minutes. I'm just going to start sharing my screen. All right, perfect. Hope everybody's having a nice evening, nice warm day today. It's kind of nice. A little break from the cold weather. Okay, let's see. So we have 15 people. I think we'll get started. We're expecting quite a few more, but I don't want to lose a lot of time at the beginning. So let me go back here. Hi, everyone. My name is Nina Resetkova. I'm a fertility physician at Boston IVF, and I practice out of a couple locations. Right now, you're joining me in my Quincy office in the South Shore Center, and I also see patients out of the North Chelmsford location. So a pretty wide geographic net. And today I'm going to be talking about LGBTQ plus fertility and questions on donor sperm as well. So pretty broad topic. We'll give a little bit of an introduction and then, take it from there. And these sessions are always interesting because there's always a little bit of a different set of questions each time. So feel free to ask questions as anonymous, or if you want to share your name, that's fine too. And if any of my patients are joining in, hi everyone, and I look forward to the session. All right, 7:03, so I think we'll jump in, okay? So a little about me. So I'm a fertility physician, originally from Toronto, Canada. Lovely picture of Toronto up there, right on the water. I went to college in Montreal, Canada, so that's where I kind of grew up. And then I went out to the Wild West in West Texas to go to medical school. And then I came back closer east to Johns Hopkins to do my residency training. And I have now been in Boston for about 8 years. I did my fellowship training here in fertility medicine at Boston IVF, Harvard Medical School, and Beth Israel Deaconess Medical Center. And I've now been working as a physician at Boston IVF for about 5 years. And one of my areas of passion and interest in both and from a clinical standpoint and from a research standpoint is LGBTQ plus fertility. So I'm very happy to share in some of that knowledge with you all today. So jumping into a little bit about what you're here for today, obviously to gain a little bit more insight, a little bit more information. You may be at the very beginning of your fertility treatment journey. You may be already in progress, either at our center or a different center. You may just be wanting to learn a little bit more about kind of a new science, should you need any treatment in the future. So information is really the first piece. Also, you need, when you're selecting a treatment center, you need respect, recognition of your personal status, your relationship status. You need a treatment center that has experience working with the LGBTQ plus population, if you identify as such, and really, I think, a partner in the process of family building. So that's, what we're here for. Boston IVF has been caring for the LGBTQ population since our inception, which, 30 plus years ago, a lot of families, we've helped to build a lot of families in that time frame. So I wanted to jump into kind of what is a reproductive health checkup. Sometimes that can be intimidating to come in and see a fertility specialist. You may have the question, do I need to even see a fertility specialist before starting my journey with donor sperm insemination? And so just to kind of debunk it a little bit, the first visit is typically a 1-hour appointment with a reproductive specialist. So that's somebody like me who's had training both in obstetrics and gynecology, and now focuses on reproductive medicine and reproductive surgery. At your visit, we'll review your medical history, potentially your partner's medical history in detail, make a plan for fertility testing, potentially if you've already had testing before, or you're a patient at another center, make plans for fertility treatment at that time too. Although usually we're just starting with fertility testing at the beginning, okay? We will also review potential treatment options and associated timelines and costs. So we have teams at Boston IVF. And so when you establish with a team, there's nurses associated with the team, medical assistant, and financial coordinators as well. So a really important part of the process is understanding what are your benefits through your insurance? Do you have coverage for certain treatment options? What are those? And then if you're going out of pocket, self-pay, what are the expected costs of the associated treatment? So needless to say, Boston IVF, we are a full spectrum fertility care center. We do all aspects of fertility care. So that stems from as early on as just fertility testing and a fertility evaluation through natural cycle monitoring, kind of less invasive things, insemination, of course, IVF, egg freezing, egg donation, surrogacy, and a treatment that some of you may just be learning about for the first time, a form of IVF treatment called partner-assisted reproduction. So first things first, what is a typical evaluation for somebody who's born with a uterus and ovaries? Well, one of the first steps of that evaluation includes an ultrasound. An ultrasound's usually done at the early part of a menstrual cycle. If you menstruate regularly, that's usually when it would be done. It's also possible to do it outside of that time frame, but it tends to be the most informative early in the menstrual cycle. And if you're comfortable with it, we recommend a transvaginal ultrasound because it does give the most information. It allows us to see the ovaries, which even on this little picture, you can tell are quite small, typically about 2 to 3 centimeters in size. So a pelvic ultrasound will help evaluate the uterus, the shape of the uterus, if there's any issues with the uterus like fibroids or polyps, and then evaluate the ovaries. And the really neat part about the ovarian evaluation is we're actually able to tell how many potential eggs are developing on the ovary at the same time. So that gives us a good sense of the potential of the ovaries or the ovarian reserve. There's also some blood work that's usually done at the beginning of your cycle. And that blood work consists of a testing to evaluate the function of the ovaries, some general health testing, especially if you're interested in carrying a pregnancy, STD or viral testing, genetic testing. Genetic testing is really helpful to evaluate for any genetic carrier conditions and also to help select a sperm donor as well. And then something that I'm sure we'll get some questions on as well is CMV testing for cytomegalovirus, which is an exposure that a lot of people have had. Most people have antibodies against it, some people don't. And it is a selection tool to help determine which kind of donor you'll be eligible to work with. The other test that is really, really helpful is an HSG, which is a study called the hysterosalpingogram. And you can see here, let's see if I have my pointer. Okay, yes, I do. So this is a study of the inside contour of the uterus and the fallopian tubes. And what's really, really great about the study is it's sort of like a 3-in-1 test. So it helps to evaluate the shape of the uterus, which is what you're seeing here. It's sort of like an upside down kind of T shape, or excuse me, like a right side up T shape or upside down triangle. And then you also can see the contour of the inside of the fallopian tubes. Here, the right tube, and here, the left tube. And so you're able to see if the fallopian tubes are open and the shape of the uterus. The really beneficial part of this study, of completing the study before completing insemination with donor sperm, is that you know if your tubes are open, if the tubes can receive sperm to meet the egg. And that's important because insemination with donor sperm and really purchasing donor sperm is expensive. Financially, emotionally, physically, it's a lot to go through, treatment cycles. And so you want to be sure that anatomically everything looks good before moving forward. So I recommend doing this test before getting started with insemination. All right. And so some people ask, why do I need to do a checkup before starting treatment with donor sperm insemination? Heterosexual couples don't necessarily do any sort of testing before starting to try for a family. And that may be true, but there's also a lot less expense, for heterosexual couples before they're starting for a family. And so you kind of want to make sure you allocate your resources well and you have full information. And so the other things that a reproductive health checkup will do is review your medications, make sure that your medications are all safe and compatible with pregnancy. Manage and help optimize any underlying health condition. Also preconception counseling, so how to optimize your health getting ready for pregnancy. And then also identify and treat and potentially correct gynecologic issues like fibroids, irregular periods, and polycystic ovarian syndrome, as well as endometriosis, which is a condition associated with scarring in the pelvis. So it's pretty helpful to have all this testing done beforehand and oftentimes covered by insurance as well. So how do we optimize health prior to starting treatment? Well, reviewing healthy habits like regular exercise. So we recommend about 150 minutes of exercise per week, distributed over the course of multiple days. So, you can do more intensive activity, about 50 minutes per day, 3-4 days a week, or break it up into, lighter activity, for example, walking briskly 5 days per week for 30 minutes per session. So making sure you're getting regular activity, regular exercise, particularly in these sort of more gloomy winter months. Optimizing healthy weight and healthy diet, healthy, well-rounded diet. Those are all important factors. And notably, we do have a nutrition program available through our DOMAR Center, which is part of our center in Waltham. So we do have a nutrition counseling program as well. Okay, some pre-pregnancy considerations if you're interested in carrying a pregnancy. Minimizing alcohol. So definitely less than 7 drinks per week. So that is less than 1 drink per day on average, and best to minimize below those levels. No recreational drug use, avoid marijuana use, stopping smoking, all types of inhaled smoking, and then making sure to take prenatal vitamins on a daily basis. And ideally, you start a prenatal vitamin 2 to 3 months before starting your treatment journey, because many of the treatments have very high chance of pregnancy potential. And you want to make sure you have enough folic acid on board to decrease the risk of neural tube defects. All right, so here we're getting into kind of the meat of the talk today. And I see more and more people joining on, which is awesome. And there's some questions that are popping up in chat and Q&A, which is great. So we probably have about 5 or 10 more minutes in this little talk, and then we'll jump right into the questions from there. Okay. So treatment options that we'll be talking about a little bit, insemination, fertility preservation, IVF, reciprocal IVF, and egg donation surrogacy. We're not going to talk too much about those last ones, the egg donation and surrogacy options, because although they may be part of some people's treatment journey, it's probably not the main focus of today's talk. All right, so we have a little picture here of artificial insemination. There's different ways to do an insemination. So if you're doing an insemination at home, typically the sperm would be deposited vaginally outside of the cervix. And then there's also the opportunity to do a clinic-based insemination where the sperm is processed, made compatible with transfer into the uterus, and inserted up into the uterus. We generally recommend, if you're under the age of 35, to complete 6 cycles or more, depending on certain factors. And if you're greater than 35 years of age, because the success rates can be a little bit lower according to increased ovarian aging, about 3 to 6 cycles of treatment, depending on your individual circumstances. There's lots of different ways to do even a clinic-based insemination. There's lots of ways to modify the cycle. You can take medications beforehand. You can do monitoring of the cycle. You can use a medication to trigger the release of the egg at a very specific time. And some of the costs in treatment coverage sort of varies depending on those approaches. And just to give you like a basic idea about cost, at our center, it's about $450 for an insemination, and that would be for home-based monitoring, like with ovulation kits, and about $1,100 for a monitored cycle. And some insurances, for example, Blue Cross Blue Shield, and several other plans actually have really comprehensive coverage for monitoring and treatment. So IVF stands for in vitro fertilization, and IVF is a really highly successful treatment strategy. Usually not the starting strategy. Usually for most people interested in working with donor sperm, it's going to be starting with insemination, but there are cases where IVF would be best at the beginning. And so IVF basically involves taking injectable hormones and having some very regular blood work and ultrasound appointments to monitor the development of the eggs. Surgery is needed to remove the eggs from the ovary, and that's under anesthesia. And then an embryo, or in some cases multiple, but usually one embryo, is transferred back into the uterus in order to carry pregnancy. Cost is expensive if you're paying out of pocket. Many insurances have treatment coverage for this, but sometimes you need to satisfy a certain number of attempts at insemination before being eligible for treatment. We are seeing some insurances that don't have this requirement actually more and more, so that's great to see. There's also a really cool treatment option called Reciprocal IVF. So this would be for a treatment option for two partners, both with a uterus and ovaries. But don't necessarily need to have both parts at the time of treatment, but one partner will undergo egg stimulation. So that one partner needs to have ovaries with a good egg yield, and the second partner needs to have a uterus that's prepared for transfer of the embryo. And so essentially one partner is the genetic source of the eggs and the other partner is carrying the pregnancy. So really amazing opportunity for both partners to be intimately involved in the treatment process. It can be coordinated to happen all in one, or it can be done over the course of 2 separate cycles. And the success rates for this treatment are really quite excellent. We do have a robust program for transgender fertility preservation or fertility treatment for transgender individuals as well. There's several treatment options are available for transgender individuals. And, you know, if anybody's joining on who identifies, you know, some of the important features that we highlight in our treatment is possibility of not having a period prior to getting started with treatment. That can be really gender dysphoric, so people really appreciate that. We can do transabdominal ultrasound if that's something that you're more comfortable with, and occasionally less frequent monitoring in order to accommodate for people who are you know, kind of uncomfortable with the monitoring process. So in any case, if you have any specific questions about this, I'm happy to talk in more detail. I was the lead author on a study looking at fertility preservation for female-to-male transgender patients a couple of years ago. This is really a very important study that was published out of our center. And it showed that the egg yield was really good for transmasculine patients when compared to matched cisgender patients. And even when they were on testosterone prior to undergoing fertility preservation, they really had excellent yields. So happy to take more questions that are very specific to this topic. All right, perfect. So we're at 7:20, so plenty of time for questions. We can go through right till 8 o'clock, or if we wrap up earlier, then we wrap up earlier. That'd be fine too. I will keep this number up. If you have any questions, feel free to call us. This is kind of a central number for Boston IVF, and you'll be able to speak to new patient scheduling, or if you have any questions. We have a great sort of resource team who can help answer those or match you with a clinician. Okay, here we go. I'm going to start with Q&A, but we have a lot of chat too, so lots of questions to get through. So Ted asks, my partner and I each want to give birth. How should we decide who has the best chance and who should go first? Any way to tell who may have the best chances? Thank you. And that's a great question. And there's so many different ways to approach this, but I would say starting with your ages, and then doing a basic fertility evaluation for both of you would be really great, just to get a better understanding of where you're both starting out from. I would say usually the person who is older would probably be, if you're interested in both carrying pregnancy, particularly from your own eggs, the person who's older should probably start trying first, because it may be a little bit harder. But if you're both young, probably makes sense to go with the person who has the most sort of limited egg reserve in case there's any issues. And age is not a perfect predictor of fertility potential, so it's helpful to do some fertility testing to help prioritize who should go first, particularly if you don't have any sort of personal reasons that are compelling you to a certain order. So great question. And next question comes from Susan. Susan asks, what is the difference between a HyCoSy and an HSG, and what dictates which procedure is selected for you? And that is a great question. So HyCoSy is a very particular test, and it's basically a way of evaluating the fallopian tubes. Let me see if I can go back. And instead of doing this X-ray based test that I shared with you, this HyCoSy, the HSG, excuse me, the test works through ultrasound. And so one would still place a catheter through the cervix, but instead of putting this sort of radio-sensitive dye, we would instead put a combination of water and air bubbles. So the water opens up the cavity. We can see if the cavity is smooth and regular, and then we can see if the air bubbles are spilling through the fallopian tubes. And so it allows like a different method of visualizing whether the fallopian tubes are open. It's a great test. It's very well tolerated in general. But in some cases when people have had any issues that can predispose to fallopian tube damage, the HSG, is a little bit more likely to get a clean, like a interpretable result. And then on the flip side, for some people who have a lot of allergies, for example, or have any sort of contraindications to having the dye that's used for the HSG, the HyCoSy is a good alternative. So this will kind of be like a nuanced decision that your provider can help make with you as far as which test is an option. But both are really good. And I would say for most people, like 80% of people, both are really like it's kind of even, and both would be reasonable. So talk to your provider and see what the pros and cons would be, but good studies for both. Okay, so Kat says, I'm a transmasculine non-binary patient on low dose testosterone. I'm also 38 and unpartnered. I'm thinking about carrying a child solo in the next few years. Is that even possible? So Kat, it should be possible. Obviously you're still limited by the natural boundaries of aging, ovarian aging. So I would definitely encourage you to schedule a fertility consultation. Happy to help out if possible, because it's still important to see, how well your ovaries are working at this point. Even if you've been on testosterone for a longer period of time, pregnancy or freezing your eggs is still possible. And we have good demonstration of that from prior patients who've been treated at Boston IVF. So schedule a consultation. Time is of the essence, so definitely sooner than later, hopefully in the next couple of months. But happy to talk with you about all the options, and hopefully you have several good options at this point. Anonymous asks, so I mentioned some costs, and they ask, is the cost listed for unmonitored and monitored ICI per cycle? And then where do people get donor sperm from? Okay, so the costs that I went through when I mentioned that the cost of the IUI is about $450 to $500, that is for an unmonitored cycle. So that would be for the cost of the procedure for the insemination itself. And then in terms of the monitored cycle, monitoring means blood work and ultrasound, and of course the physician overview of the cycle and treatment cycle. That is a monitored cycle, and that would be about $1,100 to $1,200. And then where do people get donor sperm from? So that's perfect. We're on to our donor sperm question. So donor sperm can be obtained from a donor sperm bank. There's probably about 100 or more donor sperm banks in the country. There's a lot. But I will say the largest ones and some of the ones that we work with the most frequently are California Cryobank, Seattle Sperm Bank, and Fairfax Cryobank. Now, there may be others that you want to explore because they have like policies where they restrict the number of pregnancies that can be obtained from one sperm donor, or very specific criteria. And so you're welcome to look beyond those, but those are a good starting place. And they have generally hundreds of available donors. And so if you have restrictions or you're looking for a donor of a particular ethnicity, or there's certain criteria that are very important to you, it's best to sort of expand your search and even try to consider looking at multiple sperm banks just to make sure that you kind of feel like you get what you need. Okay. And one thing to note as well is that we do have some donor sperm available from Seattle Sperm Bank at our center in Boston IVF. So that would be for a little bit of a lower cost for you if you're choosing from that more limited inventory, because the sperm's already at our center in Waltham, and so you don't have to pay to ship it there, and the price point is pretty reasonable as well. All right, Candace asks, if somebody tests negative for CMV, cytomegalovirus, should they only select donors that are CMV negative? So the answer to that is yes, that is the safest thing to do, because CMV is a viral infection. The risk of transmission from donor sperm from insemination is extremely low. However, the safest thing is to select a CMV negative donor if you're negative for CMV, so you don't run the risk of contracting CMV from the insemination vial. Again, risks are very low, but that is the safest approach. All right, Anonymous asks, if we aren't scheduled with you at Boston IVF and are seeing a different provider, then how do we know they are culturally competent to take care of LGBTQ people? That's a great question. Actually, our providers undergo training to gain a broader sense of LGBTQ cultural competence. So that's something that you can kind of feel good about. And then, we have a very, open culture. We take patient feedback really seriously. So, we're always striving to improve our competencies. So, happy to help if I can, but be assured that we have a wide-ranging education program for all of our providers, and that includes, our other staff as well. Staff that you interact with on the phone, or the nursing teams, et cetera. So hopefully that answers your question. All right, how much sperm do you recommend we buy per child and hope to conceive? And this person says, and I'm glad that they say this, I'm sure this is a very patient dependent question, but if there's a general rule of thumb, we'd love to know. So, I do a good number of these talks, and the general consensus amongst the sort of providers and also the sperm banks, who keep a lot of data on this and how many vials people will actually end up using for one pregnancy attempt, is about three or four vials. That's like a very general estimate. Talk with your care provider, but 3 or 4 is kind of a good rule of thumb. Doesn't mean that if you want 3 kids, you have to buy, 9 to 12 vials right out of the gate. You can certainly do it in sort of smaller allotments, and you might be lucky. You might be one of those patients who gets pregnant on their first. So, keep in mind, this can be a little bit of like a moving target, but do keep a close eye on the inventory for your donor, because if you do become pregnant or your partner becomes pregnant, you may want to purchase more at that time. So keep an eye if that inventory is dwindling, because you may want to kind of snap up some more vials. And then some donor sperm banks also have a sibling kind of program. So certain donors may retire. They may not wish to donate actively anymore, but they may be willing to come back for sibling matches. And so that would be, something to keep in close communication with the sperm bank as well. Okay, is there a freely available resource like a website or book or journal where we can learn more about optimal nutrition when going through fertility treatments? That's a great question. I don't know of a singular resource. I can point you to one. It's not free, but you'd probably be able to find some aspects of it free. Maybe if you look on Amazon, for example. There's a great book that was written by one of our nutritionist, Hillary Wright. It's called the PCOS Diet Plan. That's more specific for people with PCOS, polycystic ovarian syndrome, but that is actually generally a very good fertility friendly diet guide. It looks like we're going to get a resource from our marketing team, so you might get some information, and I know we have some information on our website, but Emily's probably going to give you something, and I may be able to share that with everyone. But there's a lot of good resources online as well, but I don't know of one particular one, so maybe we should work on that. Maybe next time you're with us, we'll have a better resource guide for that. All right, so okay, some folks saying hi. Shale asks, can I say why I'm more interested in LGBTQ health? I've always been interested in helping people expand their families and expand access to fertility treatment. There's also a real void in research in this area, and we at Boston IVF have such a really robust data that we can help contribute to help other individuals who may not be getting care in such sort of resource-rich settings. And I'm a long-term ally of the LGBTQ plus community, so I'm just kind of doing my part to help everyone gain access to the treatment they deserve. All right, a couple more questions here. Hi, Shirley. Okay, we have a question here. I just had my first failed IUI cycle. What is the success rate for medicated IUI cycle? And on average, how many IUIs does it take to achieve pregnancy? So success rates really depend on your starting age, okay? If you're under the age of 35, the success rates are typically around 15 to 20% per treatment cycle. Okay. If you're over the age of 35, they can be lower, and they can be lower, particularly if you're over the age of 40. The things that influence the success rate are also, it's very important to know that history of infertility. So if you've had prior exposure to sperm and not been able to conceive, that will influence the success rate. We already talked about age and any coexisting medical conditions or fertility issues. So generally quoted about 15 to 20% per treatment cycle. And there is some drop off in the success rate per cycle once you hit about 3 or 4 cycles. It's not to say that people don't become pregnant after that time. It's just that the success rate per treatment cycle is not as high. Okay, let's see. Okay, so we talked about the cost of unmonitored versus monitored inseminations. We got to that. All right, next question. And just to give everybody the time, say we've got about 25 minutes left. So I think we're doing a good job getting through. After IUI, should I wait 2 weeks to do blood work, or should I do a home pregnancy test? So I guess it depends. I mean, if you're doing the treatment at home and it's a home-based, I'm assuming this is a clinic-based IUI since you're referring to intrauterine insemination. So if you're doing treatment at home, you can wait for your period, see if it comes, and then check a pregnancy test if your period doesn't come. If you're doing it in the office setting, you should do clinic-based pregnancy tests, so serum HCG or serum blood test. The reason that that's helpful is because it can help to determine whether you're pregnant or not pregnant, but also whether there's any weekly positive implantation, because that may help determine kind of next steps of treatment as well. So the blood-based test is always advised to make sure also that you're not pregnant before doing another treatment cycle. So I would recommend doing that. You can do a home pregnancy test beforehand, but sometimes it can kind of muddle the results a little bit. So it's best to do the clinic-based one. And if you can wait until the result comes in, try to wait because it'll make it easier. It'll make it easier for you. All right. Patient also asks, if you gave birth from your first frozen transfer, when and how long should you wait to do the next embryo transfer? So that is also depends. A lot of these questions kind of depend on the circumstances. The earliest generally is about 6 months postpartum if you had an uncomplicated pregnancy and uncomplicated vaginal delivery. If you had a C-section, it may be safer to wait to a year. In rare cases, 18 months. But it really depends on the circumstances of your pregnancy. Also depends on your age and what kind of treatment you may need as your next step. But if you have nice embryos and you're healthy, usually that 6 to 12 months is a really popular time to come back and do the repeat embryo transfer. Okay, and I think I answered where do people generally get donor sperm from, so hopefully that was satisfactory. Stephanie asks, how long does the process typically take from start to finish with the understanding that there are no complications? So we'll answer that for donor sperm. I think that's probably the best way. So most people come in for consultation. It may take, depends, maybe like a month or two to get an appointment, something like that, very sort of a reasonable time frame. So if you're calling to book now, something in January certainly would be possible. And so you would schedule an appointment and then do some fertility testing. The testing typically takes 1 month because it is timed to menstrual cycle. And then the following month can be for making a plan with your fertility provider and then running that plan through insurance if insurance is going to be involved in paying for any aspects. If you're not going through insurance, if it's self-pay, it's usually faster because you don't have to wait for the insurance authorization. So in total, like let's say you're establishing as a new patient, you'd probably be able to get seen maybe early January, mid-January, and then do fertility testing and meet back with the doctor at some point in February and starting treatment as early as March. If you're already established, sooner. And if your cycle happens to align with the appointment, you may be able to jump right into testing. That's also an option. It can help move things forward a little bit faster. And so to become pregnant, as we said, most people need about 3 or 4 inseminations. That's kind of a very average amount. So you can do inseminations back-to-back months. You don't have to. It doesn't change anything medically speaking about the success rates if you're doing them back-to-back or taking time off. But if you are doing them back-to-back, then I think hopefully pregnancy by the summer. All right, Emily asks, from what I've read, frozen donor sperm has a much shorter life than unfrozen sperm. What are your thoughts on proper timing using ovulation kits when sperm might only live for 6 hours and you could ovulate anywhere from 24 to 48 hours after positive ovulation kits? So that's a great question. And that's a very, I would say a very well-informed question. Somebody who's probably been doing some treatments or already, has evaluated options. So ovulation kits are a little bit tricky sometimes because you may get varying degrees of positive of ovulation kits. So I would say the first piece of advice, if you're using ovulation kits, is that you want to become really familiar with them. Do a month or 2 on your own before you're starting treatment to make sure you really understand what a positive looks like. And then the second sort of add on to this is that you can use ovulation kits, and you can also use a trigger shot to help release the egg at the correct time. So it is possible to sort of optimize that timing by using both layers. Frozen thawed sperm should live longer than 6 hours, probably more like 12 to 24 hours. So you should have a longer window, but it is true that frozen thawed sperm does have a shorter sort of swimming life than fresh sperm. Fresh sperm can live in the reproductive tract, we think, for up to 5 to 7 days. So it is a little bit different in terms of the timing. So if you're concerned at all about getting the timing right, particularly if your ovulation is difficult to track, then a couple of considerations are to do a monitored cycle with blood work and ultrasound. And then particularly the second one is to use that trigger shot to release the egg at a very particular time, so you know you're getting that window right. Okay, Katie asks, during the reciprocal IVF process, do you harvest more than one egg? And can you freeze those surplus ones for future use? And the answer is yes, definitely. We try to harvest as many eggs as possible. I would say usually in a partner-assisted reproduction or reciprocal IVF cycle, because there's usually not a history of infertility for the partners undergoing egg retrieval, the responses can be very robust. So on average, maybe between 8 and 15 eggs, maybe even 8 to 20 eggs, depending on the starting egg count. And those eggs will be inseminated with donor sperm, and embryos are created. And so it was actually the embryos that are cryopreserved or frozen for future use. And I would absolutely recommend freezing surplus embryos to help you expand your family in the future. All right, Janelle asks, what does the monitoring process for ovulation entail? So the monitoring involves blood work and ultrasound. Blood work and ultrasound appointments of Boston IVF are typically done between about 6:30 and 9:30 a.m. And we are full year operation, 365 days a year, so they can be done all the way through. They are fairly quick. So they're usually about 5 or 10 minutes for blood work, about 5 or 10 minutes for ultrasound. And so you're in and out of the office, within 15, 20 minutes. And ultimately, it's pretty quick. So it's designed for people who are working, and we try to accommodate as many working schedules as possible. And so, try to make it as efficient for you as possible. We do have same day results as well. Okay, Emily asks, we just started our 6th IUI cycle of Boston IVF. I did all the fertility testing and everything came back normal. I exercise regularly and eat pretty healthy and take the supplements recommended by Starts with the Egg. Is there anything I can do to increase my chances in this last IUI before switching to IVF? So, Emily, one of the things you could consider if you haven't done monitoring yet is to consider monitoring. If you haven't done the trigger shot yet, consider the trigger shot. And then something you could discuss with your provider too is whether it makes any sense to try a medication to help you ovulate more than one egg in one cycle, like an oral medication like Clomid or Letrozole, and see if that's safe for you. It has to be safe in the regard that there could be a slightly higher risk of multiple pregnancy, like twins. So, I don't know your individual medical history, so I can't make that recommendation, but that would be something you could definitely talk to your provider about and see if it's something that they would consider in your particular case to optimize your chances of success. And then the other thing too, it really comes down to kind of a cost question too. You can do 2 IUIs in one cycle. All the data points to success rates only going up like marginally, about 1 to 2% per treatment cycle. But if you are doing kind of a last effort to optimize your chances before going forward with IVF treatment, which is obviously more aggressive, more invasive, then you could try these efforts to kind of maximize your chances for that last cycle. So definitely a number of things to consider discussing with your provider. And keep up the exercise and healthy diet. That's very good. All right. Okay. So the question is, The next question is, if you get pregnant naturally after a prior miscarriage, should you use baby aspirin? Also, what about progesterone supplements? So baby aspirin, there's a lot more data now about baby aspirin for more high-risk pregnancies. So I would say there's more safety data about it, but you should always talk with your provider before starting a new medication regimen, particularly baby aspirin, as there can be some bleeding implications. So it's not like a catch-all for everybody, but it's a consideration. And then progesterone supplements may be a consideration if you had prior miscarriages, particularly if you've had several prior miscarriages. Progesterone supplements probably won't make the difference between successful outcome and unsuccessful outcome, but there are a small subset of people who don't produce adequate progesterone. And because progesterone is generally very well tolerated with minimal side effects, it is oftentimes a reasonable intervention for people who've had particularly multiple pregnancy losses. So definitely talk with your doctor. This is a very it was to be different for everybody, so to be an individualized recommendation, but those are definitely things, interventions to consider. And those are also generally interventions with minimal risk. So they can be appropriate for actually like a wider subset of people. Okay, Meg asks, how much is weight a predictor of success of IVF? And this particular patient says, my body mass index, or BMI, is just crossing in the overweight category. So body mass index is like very strictly defined, and there's categories based on your height and your weight. And a body mass index of up to 25 is considered normal weight, and 25 and above is considered overweight. Meg, so actually, interestingly, the success rates for slightly overweight patients are really not much different than normal weight individuals. There can be pretty significant decreases in success rate if you fall into the obese category or the underweight category. So definitely something to talk about with your it could be actually your PCP, your OBGYN or your fertility provider, about what kind of goals you might set for yourself to really optimize your health. If you're not in a huge rush and you're fairly young, maybe in your 20s, early 30s, you may have some time to optimize your health before getting started with pregnancy planning. And so those are good things to talk about too at like a preconception counseling visit. Nancy asks, is an HSG and a sonohysterogram standard? Are both necessary? And I would say in some cases, both are necessary. They're separate procedures. HSG is a dye test actually that we're, I think, still looking at right now. Sonohysterogram is a test where we put water in the uterus and kind of open up the walls of the uterus to make sure the walls are smooth and regular. And in some cases, both are indicated based on your medical history. The HSG probably gives a little bit more information because it looks at your fallopian tubes too. But they're definitely helpful before proceeding with donor sperm insemination. So, if your provider has recommended them, it's probably because, it's going to make your treatment potentially more effective or more cost effective for you. Or maybe there's something in your history that suggests that there could be a higher risk of having some pathology in the uterus that would, put you at risk for having treatment, failure. So it'd be important to evaluate. All right. Amy asks, other than natural cycle IUI with trigger shot, are there additional medication options for same-sex couples without infertility issues? I've had 3 failed IUI cycles. Okay, yes. So Amy, there is the option of adding in oral medications to increase the number of eggs that you're producing per treatment cycle. Around, having completed 3 IUIs, I think it's sort of a reasonable time to talk about this with your provider. So oral medications are typically Clomid is a first-line medication. Clomid is a fertility medication that's been around for 60 plus years, and lots of safety data on it. say about 90% of people do really well on Clomid. About 10% of people have some side effects that make it not as desirable medication to keep using. So, it's not for everybody, but most people do fine on it, and it helps to produce multiple eggs in one treatment cycle, 2 or 3. So there is the risk of multiple pregnancies, as we've outlined, but it may be reasonable after completing 3 to try it, or talk with your provider about it to see if it's reasonable for you. The other medication that you may hear about, particularly if you have irregular cycles or polycystic ovarian syndrome, is called letrozole. And letrozole is also an oral medication. It's taken in a similar timeline to Clomid at the beginning of your cycle, but it works better. It's been compared in multiple head-to-head studies in comparison with Clomid, and it works better for people with polycystic ovarian syndrome. So that is something to to consider as also an alternative if people don't tolerate Clomid treatment well. Okay. All right. So we're doing well. We're doing well. Okay, about 10 more minutes. Amanda asks, why are twins frowned upon for IVF? Wouldn't transferring 2 embryos give you a better chance of pregnancy? Amanda, great question. I don't know how old you are, but in the 90s and 2000s, actually IVF got a lot of criticism because there were a lot of not just twin strollers, but triplet and quadruplet strollers, going around because people had really high rates of multiple pregnancies. So it's interesting because you can actually really safely do IVF treatment while not increasing in a marked way, increasing the risk of multiple pregnancies. Twins and very much even more for triplets and quadruplets have much higher rates of issues with pregnancy, issues for the person carrying the pregnancy. And really the main issue, what it comes down to is there's a much higher risk of prematurity. So delivering the pregnancy early. And so twins actually have a 7 to 10 fold, so 7 times to 10 times increased risk of going to the neonatal ICU in their sort of post-birth course compared to a singleton, so 1 baby at a time. So there's dramatically increased risk for the pregnancy. There can be long-term complications of prematurity. So, we really want to optimize the health of your pregnancy. And so really working on optimizing single embryo transfer, putting back 1 embryo when possible. And in some cases, it's medically appropriate to put back multiple to increase the chances of success, but typically not as a first step in the journey because the goal is really 1 healthy baby. Okay, perfect. So we're going to go back to our Q&A session. And we have 6 more questions and probably about 6 more minutes. So I'm going to try to go quick to get all your questions. If you have any last minute questions or we're not able to answer, then actually Emily and our marketing team will be taking down some questions, and she may be able to get those last minute questions. Maybe we can email you. Okay. So Anonymous asks, do you or other specialists notice if COVID had any effect on donor sperm availability? Yes, it did. And I know this from speaking to some folks at California Cryobank. So I know that they have some more limited inventory as a result of donor sperm. It also had some effects on egg donation as well. So yes, from what I've heard, the inventories are building back up, but it's a slow road because there was definitely impact of COVID. And then, basically there were issues with continuing to have donors produce. Okay. Katie asks, during reciprocal, oh yeah, we already answered this one. Okay, so we're getting some similar questions on both Facebook and directly, so that's why we're getting some duplicates. Katie asks, how much does freeze cost typically? Okay, so I think Katie's referring to freezing embryos. And Katie, interestingly, freezing embryos is a part of IVF treatment or reciprocal IVF treatment. Is often actually included in the price of the treatment for a limited period. And so that's not always the case, but often the case. And so freezing of eggs or embryos is usually included for some period of time, whether it be 3 months or 12 months. And then beyond that, to keep a specimen like eggs, sperm, or embryos frozen at Boston IVF, it's about $100 per month. Okay, so just so you know, because that would be something you'd want to plan ahead for from a financial perspective as well. Okay, Christine asks, can you explain what the trigger shot is? Yeah, so the trigger shot, there's multiple different varieties, but in general, the trigger shot is a medication that has that is composed of HCG. HCG is the pregnancy hormone. And the pregnancy hormone has a very similar breakdown to luteinizing hormone, which is the hormone that's responsible for ovulation. So when you take HCG in big doses, high doses, it mimics the activity of luteinizing hormone, which is that ovulation tracking hormone, and it induces release and maturation of the egg. So when you take the medication taken by injection, usually subcutaneously, so just underneath the skin, the short needle, the egg will release within about 36 to 42 hours. So that is the injection in a nutshell, and it works very well. There's multiple kinds, multiple brand names, but they generally work in that way. Okay, we have got one last question, perfect timing. The anonymous asks, when checking with our insurances to see what treatments they may or may not cover, where can we find diagnosis and treatment codes so we can give them the most correct information to check? That is a great question and a tough question. Typically, you have to ask the fertility clinic for this correct coding because it may be hard to find, you know, and you really need to know from your doctor as to how they're billing your care. The good news is for coding for fertility evaluation, procreative counseling, most insurances will acknowledge the procreative counseling code for evaluation of fertility or infertility. So that is an easy code to use, and we can provide you with that if you need it. And then if you need more specific coding information, you can call your care team, and we can provide you with some insight into that so that you can get a better idea of, you know, what kind of costs you might be up against. And I see just one last chat question. Okay, yeah, and so Emily from our marketing team has put some more information for everyone to ask fertility related questions. So if you have a question, you can click on the link and then ultimately ask a question. You know, we can get back to you in some sort of reasonable time frame. And very happy to help any of you who might be interested. So feel free to schedule a consultation. And if you have sort of enjoyed this and you want to join us for future discussions, we have a lot of sort of regular Facebook Live sessions. And then I usually like to do a session around Pride Month, you know, maybe a little earlier. So feel free to keep an eye out on the social if you want to keep updated. But I enjoy doing these sessions. So if you guys have any questions, feel free to send those to Emily, and we can do another session at some point, maybe in the spring. Okay. Have a wonderful evening, a great holiday season, and thanks for joining in. Okay. Have a great night. Bye, everyone.